A toilet-trained child returns with another culture-confirmed urinary tract infection. The ultrasound is reassuring. The reflux may be low-grade, or there may be no reflux at all. Yet the infections continue. Before ordering another scan, changing antibiotics, or discussing surgery, ask a different question. Is the bladder filling and emptying normally? And is the bowel functioning normally? Bladder and bowel dysfunction may be the missing diagnosis. In this episode, we will examine how to recognize it, evaluate it without overtesting, and treat the modifiable functional risk behind recurrent urinary tract infection. Bladder and bowel dysfunction is not one symptom and not one test result. It is a clinical pattern in which lower urinary tract symptoms coexist with constipation or another bowel elimination problem. The urinary clues may include urgency, frequency, daytime wetting, holding maneuvers, infrequent voiding, straining, a weak or intermittent stream, and a feeling of incomplete emptying. The bowel clues may include hard or painful stools, stool withholding, infrequent defecation, large stools, or fecal soiling. The infection history also matters. Ask whether infections were truly culture-confirmed, whether they were febrile, and whether urgency, wetting, or constipation persist between infections. The key is to ask about both systems during the same consultation. Why can bladder and bowel dysfunction increase infection risk? Several mechanisms may coexist. A child may postpone voiding and suppress urgency for long periods. During voiding, the pelvic floor may fail to relax, the flow becomes staccato or interrupted, and the bladder may not empty completely. Residual urine then provides a setting in which recurrent infection becomes more likely. Rectal loading may further worsen urgency, reduce functional bladder capacity, and interfere with pelvic floor coordination. This relationship is not purely mechanical, and we should avoid oversimplifying it. But clinically, storage dysfunction, dysfunctional voiding, constipation, and incomplete emptying often reinforce one another. Treating only the urine culture leaves this cycle intact. The evidence is clinically important. In a combined analysis of the RIVUR and CUTIE studies, bladder and bowel dysfunction was present in 54% of toilet-trained children assessed after urinary tract infection. Most affected children reported daytime wetting, withholding maneuvers, or constipation. Among children who were not receiving antimicrobial prophylaxis, recurrent urinary tract infection occurred in 51% of those with both bladder and bowel dysfunction and vesicoureteral reflux. The corresponding estimate was 20% in children with reflux alone. These are subgroup estimates, not universal probabilities for every child, but they illustrate a critical point. Reflux grade alone does not define infection risk. Functional bladder and bowel status can substantially change the clinical phenotype. Evaluation should begin with structured clinical information, not invasive testing. First, confirm that the previous episodes were genuine urinary tract infections using symptoms, an appropriate urine specimen, and culture results. Second, take a focused bladder and bowel history. Third, use a voiding diary for at least 2 days. Record voiding frequency, volumes when possible, wetting episodes, fluid intake, and stool pattern. The Bristol Stool Scale can help describe stool consistency. Examine the abdomen, perineum, lumbosacral spine, and lower limbs for anatomical or neurological clues. Urinalysis and culture are appropriate when infection is suspected. Renal and bladder ultrasound, including post-void residual, is useful when the infection history, emptying symptoms, or examination justify it. Uroflowmetry with pelvic floor electromyography is a targeted test for suspected dysfunctional voiding. Invasive urodynamics, spinal imaging, and cystoscopy are not routine for every child. First-line treatment is standard urotherapy combined with active bowel management. This is not simply advice to drink more water. Create a regular voiding schedule and reduce prolonged holding. Teach a relaxed voiding posture with the feet supported and enough time to empty without straining. Distribute fluid intake through the day. Treat constipation, and prevent stool reaccumulation. The bowel plan must be specific enough for the family to follow and should be reviewed over time. When incomplete emptying is clinically relevant, double voiding may help selected children. Use a diary to track symptoms, adherence, stool pattern, and infections. European guidance recommends adequate bowel management when bladder and bowel dysfunction is present and advises treating bowel dysfunction first, because lower urinary tract symptoms may improve after successful bowel treatment. Treat both systems from the beginning. When the child does not improve, do not immediately label urotherapy a failure. Reassess the diagnosis and the implementation. Was the original infection culture confirmed? Is the child actually following the voiding schedule? Has constipation been adequately treated, or has stool retention returned? Is post-void residual persistently elevated? Does the flow pattern suggest dysfunctional voiding, underactive bladder, or possible anatomical obstruction? Look again for neurological findings, sacral abnormalities, abnormal genital examination, upper tract changes, or an atypical infection pattern. Treatment failure is often useful information. It may reveal poor adherence, an incorrect phenotype, or a more complex disorder that was not apparent at the first visit. Escalation should remain phenotype-directed and stepwise. For suspected dysfunctional voiding, repeat uroflowmetry and post-void residual under representative conditions. Pelvic floor electromyography may help confirm inappropriate activity during voiding. Biofeedback or pelvic floor physiotherapy can be added in selected children who remain symptomatic despite standard urotherapy. For a well-defined overactive bladder phenotype, medication may be considered after bowel management and emptying have been addressed. The evidence for many add-on interventions is less robust than the evidence supporting structured assessment and standard urotherapy, so expectations should remain realistic. Persistent high residual urine, upper tract deterioration, abnormal neurological findings, or severe refractory symptoms justify broader evaluation. That may include urodynamics, lumbosacral magnetic resonance imaging, or cystoscopy, but only when the result is likely to change management. A practical approach has 6 steps. First, confirm that the child truly has recurrent urinary tract infection. Second, screen every toilet-trained child with febrile or recurrent infection for bladder and bowel dysfunction. Third, define the dominant phenotype, storage symptoms, emptying dysfunction, constipation, or a combination. Fourth, begin standard urotherapy and active bowel treatment. Fifth, reassess symptoms, infection recurrence, adherence, and bladder emptying. Sixth, escalate testing or treatment selectively when red flags persist or first-line management fails. 3 take-home messages. Bladder and bowel dysfunction is common and often missed. A normal ultrasound does not exclude a functional risk for recurrent infection, and antibiotics do not correct withholding, constipation, pelvic floor non-relaxation, or incomplete emptying. Treat the bladder and bowel, not only the urine culture. This is Pediatric Urology Academy.